Ladies and gentlemen, dear professors and colleagues, I'm very grateful for being here and excited for being here. I am Milica Labus, ENT resident at Military Medical Academy, and I would like to present you our results from a 10-year-long study about choanal polyps in children and adults. Let me start with a little reminder that choanal polyps are benign, solitary, soft tissue lesions extending towards the junction between the nasal cavity and nasopharynx through the choana. The most commonly seen forms are known as enterochoanal polyps, originating from the inner wall of maxillary sinus and rising slowly through the accessory or rarely through the natural ostium. The other sites of choanal polyps origin in the sinonasal region are ethmoid and sphenoid sinus, nasal septum, middle and inferior turbinate. The etiology and pathogenesis of choanal polyps are still unclear, but it is thought that chronic inflammation, chronic lymphatic obstruction, and atopy play the roles as factors in the etiology of CPs. The aim of the study was to assess clinical and histological characteristics of choanal polyps in children, comparing to adults with same clinical entity. This retrospective descriptive study enrolled 78 patients diagnosed with CPs, treated and followed up in our Department of Otorhinolaryngology from January 2008 to December 2017. All demographic characteristics, main complaints, as well as clinical characteristics of choanal polyps, site, localization, surgical approach, histological characteristics accompanying paranasal sinus disease, association with allergic rhinitis, postoperative follow-up period, and recurrence rates were retrospectively reviewed. All patients were classified as children and adults, and all of them underwent CT scans or paranasal sinuses, and in some cases we used MRI for differential diagnosis. In majority of cases, endoscopic sinus surgery was used as a treatment of choice. In all our pediatric patients with ACPs, and in those adults whose site of ACP's origin could be easily accessed through a classically widened middle meatal antrostoma, we perform middle meatal antrostomy. In those adults whose site of ACP's origin was inferior or anterior wall of maxillary sinus, the treatment was completed with inferior meatal antrostomy. And finally, in those adults whose maxillary component of ACPs could not be seen and therefore properly cleaned, we used a combination of endoscopic and an external approach, so-called mini-calvé lick. For those polyps originating from anterior ethmoid, we used endoscopic anterior ethmoidectomy, and for those arising from the mucosa of middle and inferior turbinate, simple endoscopic excision was performed. All lesions were histopathologically studied in order to assess histological specificities of CPs in children and to eventually detect some accompanying paranasal sinus disease. Allergic status was checked in all our study subjects based on the presence of nasal symptoms, local rhinoscopic or endoscopic findings, and by the results of skin prick test and serology test. So let me tell you something about our results. Here you can see clinical and demographic characteristics of choanal polyps in children and adults. 78 patients, 22 pediatric and 56 adults were included in this study. Main complaints were the same in both groups: nasal obstruction, snoring, rhinorrhea, and epistaxis, and we found no significant difference in the prevalence of these symptoms between the child and adult. The site of CP's origin in 17 pediatric patients was maxillary sinus. 3 originated from anterior ethmoid, 1 from the middle, and 1 from inferior turbinate. In the adult group, 50 choanal polyps originated from maxillary sinus, 4 from anterior ethmoid, 1 from the middle, and 1 from inferior concha. Oropharyngeal extension was more frequently found in children, 27%, than in adults, only 7%. Here you can see extremely big pharyngeal portion of choanal polyp in a 20-year-old boy. When it comes to the surgery, endoscopic approach was used in 100% of pediatric patients and in 85% of adults. In all our pediatric patients, we performed with ACPs, we performed middle meatal antrostomy only. Due to the specific attachment of ACP stock to the inferior or anterior wall of maxillary sinus, we performed combination of middle and inferior meatal antrostomy in 20% of adult patients. To prevent recurrences, we combined endoscopic and an external approach in 50% of adult patients. In all our participants, histological analysis confirmed the diagnosis of choanal polyps. Here you can see an interesting phenomenon. It's a stromal dilated ductal retention cyst that was found in the antral parts of ACPs in 54% of pediatric patients and in 67% of adults. We found the prevalence of angiomatous choanal polyps to be higher in children, 18%, then in adults, only 5.3%. The association with allergic rhinitis was more frequent in children, as it was the presence of ipsilateral chronic maxillary rhinosinusitis without nasal polyps. We followed up our patients for at least 2 years after the surgical treatment, and we found recurrences in 3 pediatric and in 5 adult patients, all of them with ACPs, but without statistically significant difference. In those adults with recurrences, we performed middle meatal antrostomy only. However, there were no recurrences after the combined procedures. Now, I would like to draw attention to the fact that we found significantly higher percent of oropharyngeal extension in children. That could be explained by a high growth potency of CPs in children and by the fact that younger children do not have such developed possibility to report their health problems as adults. Our results are similar to the findings of Lee and others, who demonstrated higher incidence of more severe CT stage in children as a result of late diagnosis. Here you can see the presence of nasal and antral portion of a same choanal polyp in a 15-year-old boy. We also found significantly higher presence of angiomatous choanal polyps in children. That could be explained by a high activity of endothelial growth factors in stroma of children's CPs. And this phenomenon is in accordance with these 2 similar previous studies assessing the patients with ACPs. On these microphotographs, you can see the difference between the angiomatous and the regular choanal polyps in a child. Please note the presence of dilated blood vessels marked with the arrows and the lymphatic vessels, which were marked with asterisks in the stroma of angiomatous choanal polyps, comparing to the regular blood vessels in regular choanal polyp. In our study, all patients with polyp recurrences were those with ACPs, and we found higher presence of recurrences in children, but without statistically significant difference. That could be explained by the fact that performing middle meatal antrostomy only in children, we had a tendency to restrict the removal of bone structures in the region of osteomeatal complex to prevent the disturbance in the development of these very important structures during the childhood and puberty. And evidently, some kids underwent an incomplete removal of antral portion of ACPs at its inferior aspect, probably due to the fear of damaging the teeth buds, interfering with facial growth. However, the fact that we found no recurrences after the combined procedures could suggest that combined approach can reduce recurrence rates in selected patients that cannot be completely managed with endoscopic approach only. At the end, I would like to underline that according to our results, there are some clinical and histological characteristics of choanal polyps in children comparing to adults. And although endoscopic approach is safe and relatively effective option in treatment of choanal polyps, combined procedures are often needed to prevent recurrences. However, these techniques cannot be recommended in children, so we need further investigation to find an optimal technique for ACP recurrences in children. At the end, if you are curious to find more details about the study, you can find a paper in European Archives of Otorhinolaryngology where it has been recently published. Thank you very much for your attention, and I wish you enjoyable staying in Belgrade.
Thank you. Questions? Tomica.
Nice study, but one objection. Actually, you gave us a talk about antroconal polyp, not conal polyp.
Yeah.
Conal polyp is, according to Stamberger's classification, another entity, and it means that the origin of this polyp is on the frame of choana. And these polyps that you examined actually were antroconal polyps. With these three parts, one is in antrum haemori or maxillary sinus, another part is osteometal complex and in the nose, and the third part passes through choana to nasopharynx. So.
Yes.